speaker. So our next speaker is Dr. Kate Bourne, who also spoke to us last year. Since then, she's actually obtained her PhD. Congratulations. She works with Dr. Satish Raj's lab, focused on the impacts of postural orthostatic tachycardia syndrome, as well as non-pharmacological treatments, such as compression garments for that condition. She's a medical student in the Leaders of Medicine program, and during her graduate work, she held a very prestigious CIHR Vanier Scholar Award. She's completed her undergraduate degree at the University of Victoria with a BSc. And again, we're very excited that you've been able to join us. Come on up.
Great, thank you so much. Thank you. So thank you so much for the introduction. I'm very excited to be here today, both as a researcher and also as a person who has both POTS and EDS. And so that sort of inspired my research career into POTS as well as EDS. So I'm here to present some updates from the Calgary Autonomic Lab, which is run by Satish Raj. I just have a snapshot of 3 studies that we're working on. So I first just wanted to go over the physiology of standing. So if you're a healthy person, when you stand up, gravity pulls about half a liter of blood from your head and chest down into your abdomen and legs. But you probably don't even notice a difference. And that's because your autonomic nervous system, which controls automatic processes in your body, like heart rate and blood pressure, figures things out for you. And part of that is that the blood vessels in your abdomen and legs squeeze more tightly to help push that blood that's been pulled down back up to the heart. In patients with POTS, though, unfortunately, this does not go as well. So here we have a person with POTS, and they might be a little too happy. I know that there are symptoms that are not related to standing, but when they stand up here, things really have gone wrong. And there are patients have a lot of debilitating symptoms like fast heartbeat, lightheadedness, fatigue, many other symptoms I didn't list. And a lot of this is because the body or the autonomic nervous system is not responding appropriately. So when gravity pulls the blood down to the lower body, instead of those blood vessels constricting to push the blood back to the heart, the blood actually collects or pools. And when there's not enough blood getting back to the heart has to beat very quickly to make sure that there's enough blood getting to the brain and the organs. So that leads to a lot of the symptoms happening in POTS. So I know I won't go through this in a lot of detail, but I just wanted to include the diagnostic criteria. So currently the diagnostic criteria involves a heart rate increase of 30 beats per minute or more within 10 minutes of standing. If you're age 12 to 19, it's 40, and that's because people who are younger normally have more orthostatic tachycardia normally. This needs to be without a blood pressure decrease. So if you do have a blood pressure decrease when you stand up, you don't have POTS, but you might have something called orthostatic hypotension, which is another autonomic disorder. In addition to the heart rate and blood pressure findings, you need to have symptoms that are worse when you're upright and better when you're lying down. And it's important to rule out other medical conditions that you might have, and also to have a sort of a period of time where you've been experiencing these symptoms. Maybe if you've had a cold or the flu, you might feel like this for a week or so. That doesn't really meet the POTS criteria. It does need to be a bit longer. So what about POTS and EDS? I know today is a hypermobility and EDS day. So research currently shows that about 15 to 41% of patients with POTS meet the criteria for hypermobile EDS. There are some proposed but actually unproven mechanisms of how these two conditions are related, and they do get cited a lot as being sort of the evidence, but there isn't actually sort of a physiological study demonstrating this yet. So the most common one is that people with EDS have stretchier blood vessels, and therefore their blood vessels don't constrict as well, and that causes more blood pooling. Another one is related to peripheral nerve damage. So those nerves that control your blood vessel squeezing in your lower body are damaged, and therefore your blood vessels can't constrict. And then the third one is the role of vasoactive medications. So things like opioids make your blood vessels more stretchy, and therefore your blood vessels can't constrict. So these are all things that actually can be tested with research, and I think would be an important direction going forward to understand how POTS and EDS are related, but there isn't really sort of evidence yet to support these hypotheses. It's also possible that POTS in patients with EDS could be unrelated to EDS, and it's just one of the other mechanisms that causes POTS. So jumping into the 3 studies that I wanted to share today. So the first one is looking at EDS and local anesthetic. So we know that a lot of people with hypermobility and EDS report that they go to the dentist, or maybe they've had stitches and the freezing didn't work properly and they could feel everything. So although that had been reported a lot in the literature, there wasn't actually a study demonstrating that that was the fact. So we actually conducted a clinical trial where we injected saline as a control and then lidocaine as an anesthetic into the participant's arm. And we did this in a blinded fashion. So neither the evaluators or the patient knew if injection site 1 was lidocaine or if injection site 2 was the lidocaine. After the injection, we tested the sensation with a fancy poking stick called a monofilament. The monofilament is nice because you can apply the same pressure every time for consistency. And so we poked both the injection site 1 and injection site 2 at 5, 15, and 30 minutes post-injection, and participants rated how much they could feel. So what the results showed here, so this is a delta sensation score. So we subtracted the lidocaine data from the saline data. And if you had a higher number, so a score of 3, it meant that the lidocaine worked really well and you couldn't feel anything. And if you had a score of 0, it meant you could feel everything. The lidocaine did not work. So in EDS, in blue, you can see, it might be a little bit hard to see, but their median scores are actually lower than healthy at both 15 and 30 minutes. So not at 5 minutes, there wasn't a difference, but moving along in time, it did show that patients with EDS actually had more sensation or reduced efficacy of the local anesthetic. So this was pretty exciting that we were able to show in like a clinical trial that this is actually a real thing that we know patients have been reporting for a while. And so this data analysis is still in progress, but hopefully will be published soon. And this is just similar data looking at it in a different way, just the percentage of participants who had adequate anesthesia, so the lidocaine worked well. Again, at 5 minutes, there wasn't a difference, but you can see at both 15 and 30 minutes, the EDS line is way higher, or sorry, is way lower. So the participants with EDS had less effective anesthesia. So hopefully this will be published soon, and you can look for the full paper. The next project, just sort of jumping, it's a little bit of a snapshot, is the Diagnosis and Impact of POTS study, or the Big POTS survey, which might be something that some of you have participated in. This is developed between Vanderbilt University as well as Dysautonomia International, and it's a large survey of patients with POTS who self-reported medical and social information. So this study is currently active. You can still participate, but for this analysis specifically, the cutoff is November 2023. So when we pulled the data, at that time we had 10,775 participants with POTS, and then 25% reported that they also had EDS in addition to POTS, which is sort of consistent with how the survey has been going over time. Most of the participants were female, most were age 18 years, and most were white, which is also consistent with our understanding of the POTS demographic. So we looked at RAND 36 health-related quality of life, which is a way to assess quality of life in multiple domains like physical functioning, energy and fatigue, pain, and things like that. So with this score, if you have a bigger number, it means that you're doing better. And if you have a lower number, it means that you're doing worse. So in all of the physical function-related domains, health-related quality of life was lower in patients with POTS and EDS compared to no EDS. We then were able to take those individual scores and make component scores for physical health and mental health. And we were able to show that patients with POTS and EDS have lower physical health-related quality of life, but the mental health scores were not different. So we think this is an important consideration, that when patients are diagnosed with multiple things, that it really does have an impact on quality of life, and it's important to be able to treat all of the different conditions. The last study that I just wanted to quickly go over, and I think I'm potentially out of time, but maybe I'll just do this in 15 seconds, is a compression garment study that I did as part of my thesis. So this was something we wanted to do because compression garments are often recommended in POTS, but there was actually no study in adults with POTS testing them. And this led to a lot of people, I think, being prescribed knee-high compression when maybe that isn't the most effective. So we did 4 different tilt table tests, which is like a special bed that is flat, and then we tilt it up to simulate standing using these 4 different compression conditions. And just the really quick snapshot overview of the results is that we were able to demonstrate that full compression, so waist to ankle, was the most effective. It actually reduced the heart rate increase from about 40 beats per minute to 23. But abdominal compression, so sort of like thigh to abdomen, was also good, but lower leg compression didn't really do that much in terms of heart rate. Similar trends for symptoms. So for this score, a bigger number means your symptoms are worse, a smaller number means your symptoms are better. And we saw the same trend where with no compression, patients had the worst symptoms, and then full compression, it was the best. So just to conclude this sort of whirlwind look at what we're up to in the autonomic lab, we were able to show that patients with EDS do experience resistance to local anesthetic. EDS and POTS are related conditions, but more research is required to really understand the physiological relationships. Patients with both POTS and EDS have poorer quality of life than patients with POTS but not EDS, and that compression garments, including compression of the abdomen, reduce heart rate and improve symptoms in patients with POTS. So that's the end of my presentation. I'd just like to thank Dr. Raj, my supervisor, as well as my team and funding agencies. Thank you. Oh, sure.
Perfect. Okay, so we have about 8 minutes for any questions from the audience for Dr. Bourne or for Abby. And just wait till one of our mic runners comes to you if you don't mind.
For the individual that did the study with involving ADHD, it's curious to me that ADHD showed no impact on working memory, attention, that kind of stuff. So were those the only 3 factors that you measured in terms of processing speed, working memory, that kind of stuff?
Yeah, that's a great question. So we are hoping to recruit more participants to see if that is the case, as we do have still a relatively small sample size with only 12 per group. So our goal is 20, so we're hoping that we'll be able to get a better understanding of what the results are, as they might change as we get more participants. And to answer the second part of your question, we're looking at processing speed, working memory, attention, just because a lot of these validated tests are used to measure those factors. And so it'll just give us a bit of a better understanding for those.
My question is for Dr. Oh, sorry, was someone?
Go ahead, Dr. Kumar. I think, Monica, there's a question in the back for next one.
My question, thank you, was for Dr. Bourne. I think it's super interesting about the abdominal compression. I didn't know that. So, like, where should people buy them? Because it looked like in the picture they covered their abdomen and their legs, and how tight should they be? Thank you.
Yeah, that's a really great question. So in the study I showed, we did use a proof of concept garment that actually is used for bleeding after childbirth. So it wouldn't be something that we'd recommend in real life. So there's kind of like 2 options. There's medical grade compression, or there's like high quality triathlon tights. And so I didn't show for time, but I actually do have some slides. We followed this up with an at-home compression garment study where we had participants wear their own waist-high tights during the day, and both the medical compression as well as the sport compression were effective. So brands, not sponsored or anything, but certain triathlon type brands like 2XU will actually mention on their website, this is a 20 to 25 garment or things like that. So I would say don't go to like a sports store and buy like a random compression garment, but if you can find one that's high quality, or things like Sigvaris, Juzo, all of those sort of high quality medical garments are also an option. Cost benefit, the high quality medical garments, I would say 30 to 40 millimeters of mercury, they provide more compression. The triathlon tights, maybe 20 to 25, less compression, but maybe a little bit more tolerable because they are designed for sports. They're kind of easier to wear, they're less hot. I'm not sure if that totally answers your question, but I'd say like kind of online search is best, and 30 to 40 would be a medical grade compression.
Hi, my question is for Dr. Bourne as well, kind of related to the abdominal compression. And I'm interested in whether you see if people with POTS or EDS or hypermobility tend to use Valsalva or breath holding more as a compensation, because I'm thinking about the weakness in the pelvic floor, that would make it hard to use the pelvic floor to provide that abdominal compression. Do you know if there's a difference, the use of Valsalva or breath holding in this population?
That's an interesting question. So do you mean that the patient would sort of be like unconsciously doing that? So I don't know, but it would be something to look at for sure in the future.
So I have a question for each of you, but I might as well start with the breath thing since you brought that up. I'm wondering, I mean, so it is interesting to see the compression impact, that clearly things below the diaphragm are making a difference. But the question is part of the resistance happening at the diaphragm that the lower body has to overcome, and the inferior vena cava. So I'm wondering if you've considered doing something like a MARM test where you're looking for motion of different aspects, 4 quadrants of the rib cage. So the 2 upper above the diaphragm and then the 2 lower quadrants. It's been validated. It's used in, I think, by both osteopathic practitioners and physiotherapists. I think it was created first by somebody in the Netherlands. And so it's a way of kind of grading how much activity is going in each side of the rib cage between the upper part relative to the lower part. And then there's a way to score it or make an angle to reflect it. Because it would be interesting to know, the impact at that level. And because that's something that could be changed both through manual therapy and also through exercises. And then, so I don't know if you've looked much
Sure.
at diaphragm.
Yeah.
Answer that.
Yeah. So that's really interesting. So I haven't looked in that for sure. A lot of our sort of hypothesis of why abdominal is most effective is just because, like, in your splanchnic circulation, you do get so much blood pooling. Like, most of the blood that gets pulled down goes there. We do have some research ongoing in our lab that's looking at hyperventilation and POTS and things like that. So I think it could be something I could mention to our colleagues to look at in the future for sure.
Okay, and then, and just for context, I'm an osteopathic manual therapist, and I'm also an exercise physiologist. For Annie, it's Abby, sorry. I'm just wondering, related to the ADHD and learning disabilities, when I hear people who self-proclaim what they have or based on their history of assessment, that does bring up some kind of alerts of, like, how reliable is this when we know that 80% of people with ADHD have a learning disability as well? So did their medical doctor or psychiatrist do an ADHD diagnosis and they never had a learning disability diagnosis, but they would have one had they had an educational psychologist do their assessment for ADHD and it included learning disabilities? And then even with, have they ever been assessed for ADHD? Or was it ruled out? Because there's a big difference between having it ruled out and somebody who just never went the route of being assessed. And so in order to be reliable that we're looking at the same thing, I think, you almost need to do an assessment there that's consistent for everyone. And it would also be interesting to have, say, a speech and language pathologist do a listening assessment. Like, I mean, ADHD is like output, right? Like, what can you put out?
Right.
What would be interesting is knowing what's happening with input. So like with a speech and language pathologist testing for listening, like if there's background noise in one ear and then a word is said, can they filter out the background noise and still hear the word in both right ear and then left ear? And then if you have a word in each ear, can they process it? Because people with a listening processing disorder are going to have, when input is more stressful, then output is stressful. And then also testing, like, say with, Sean Gibbons, a physio out of Newfoundland who's got a PhD in an area related to neurology, but he teaches a kinesthetic or feeling memory test and a visual memory test. And I know, I've tested a couple people with Ehlers-Danlos who one of them literally has no kinesthetic feeling memory and no visual memory. If she looks in the mirror at herself and then looks away, she can't remember that picture. But she also can't remember a feeling in her body unless it's by her tongue. But then I have someone else with Ehlers-Danlos who has a 6 out of 10 for feeling memory. And so that is really correlated with levels of anxiety. And because if you're going through the world and from 1 second to the next, you have no memory of what you saw or felt. So you have no ability to do a feeling trajectory or a visual trajectory. Those two people with Ehlers-Danlos have a hugely different input stress into the brain.
Yeah, I think that's really good feedback for interpreting our studies. Just in the interest of time, we'll just take one more question, but appreciate the feedback. Just one more question from the online group, and then we'll have to move on.
So the question is, what advice would you give patients to help them advocate for themselves in regards to needing that extra local anesthetic for procedures like lumbar punctures and surgeries? And they also mention dental experiences and just how do you advocate for yourself as a patient? And
Yeah, that's a really great question. And I think it can be challenging, especially in some of the situations that people have kind of mentioned today. We're really hopeful that by having a publication that actually shows, like, you know, this is a clinical trial that shows that this is a real thing, will be something that can help patients to take to their dentists or healthcare providers to show. And maybe just help support them in getting, you know, enough anesthesia. So I don't know if that's like a really amazing answer, but that's sort of what we're hoping will be the result of our trial.
Perfect. Thank you. So again, our speakers are going to be available during the breaks. Feel free to ask them more questions, but we do have to move things along. So I'll just get our next speaker to come up and I'll start introducing them.